everyone. Thank you for accepting me this invitation, Dr. Liu. I'm very happy to have you with us tonight. So Dr. Liu is going to talk about the role of Transpetrous approaches for skull-based lesions. And so Dr. Liu completed his medical school at New York Medical College, and afterwards he completed his neurosurgery residency at University of Utah at Salt Lake City, and was awarded by the Congress of Neurological Surgeons with a Dandy Clinical Fellowship, and completed posteriorly his fellowship and training in skull-based cerebrovascular surgery and neuro-oncology at the Oregon Health and Science University in Portland. His research and other interests are mainly on the development of innovative and novel skull-based and endoscopic techniques, as well as quantitative surgical neuroanatomy and microsurgical and microvascular anastomosis skills training, and of course, skull-based tumor research. He has multiple publications on these topics. I won't go further on them. His main clinical interests and expertise are on brain and skull-based surgery, both open and endoscopic, and advanced cerebrovascular surgery. And his actual position is at Rutgers. He's an associate professor of neurosurgery and ENT, as well as director of surgical neuro-oncology at the Brain Tumor Center, and director of the Center for Skull-based and Pituitary Surgery, director of cerebrovascular bypass program, and co-director of the skull-based and endoscopic skull-based program as well. Just to remember that hopefully we will have in 2022 the World Congress of Neurosurgery, the WFNS Congress next year in March 2022. So welcome, Dr. Liu, and thank you again for accepting this invitation. Please go ahead with your talk.
Great. Thank you, Edgar. Thank you for that kind introduction. And it's a pleasure to be in your seminar to present this topic. Certainly a great honor for me. So without further ado, let me go ahead and share my screen. Okay. So today's focus will be on transpetrous approaches, and the reason why I picked this is because I think most of us, when we think about CP angle, we generally use the retrosigmoid approach, which is largely the workhorse for many lesions that we treat in the posterior fossa and the CP angle. But there are times when it's more advantageous to use a more extensive approach, and I'll show you the indications and also some technical pearls on how we can make this surgery safer and why it's more advantageous. So I want to begin with this statue of David. This is, of course, Michelangelo's David statue in Florence, and if you have a chance to visit Florence, you'll be able to see this wonderful, magnificent work of art. And in this hall, as you're walking in to see the David, you will see the hallway of various of his various unfinished works. And some people will argue that these are finished works, but they're called unfinished works. But you can see how you can visualize the end product within the stone. And when I think about this, I think this is how we have to think about temporal bone. As a neurosurgeon, we often work with neurotologists, but I think neurosurgeons should also be very well versed and very familiar with temporal bone anatomy, because there are some situations where you have to handle the temporal bone yourself. But we have to be like Michelangelo, and we have to have that X-ray vision that Dr. Roten taught us, where we can visualize the structures beneath the bone and look for key landmarks so we can excavate these structures, much like an archaeologist, such as this magnificent piece of architecture here, the Petra, right, in Jordan, where the sculptors were able to visualize this beautiful end product within the stone. So when we think about Transpetrous approaches, I tend to adopt this model that I actually learned from our colleague Jacques Morcos, where we divide the clivus into fourths, where the upper fourth is the dorsum sellae to the confluence of the superior and inferior petrosal sinuses. And this is largely accessed through FTOZ and subtemporal approaches. And as we work lower down on the clivus, the quasi or the so-called anterior petrosal approach helps us to get to this region. And if you look at this diagram, it really gets you between the fifth and the seventh nerves. And this is the key zone of access when we're using the Kawasi's approach. And then as you get lower down to the level of the jugular foramen, the posterior petrosal helps you access both upper and lower clivus regions. And below the jugular foramen in the lower fourth, at the level of the foramen magnum, this is really best approached through a far lateral transcondylar approach. And of course, we shouldn't forget the retrosigmoid approach, which is the workhorse. And then in some situations, you come in endoscopic endonasal through the clivus or petrous regions. And this is also another alternative option. But I'm going to focus more on the open lateral skull base approaches tonight. And this is really an important approach in your armamentarium to really help you get to petroclival type lesions. And it's useful for both neoplastic and vascular pathologies. We generally break up the petrosal approach into the anterior petrosal and posterior petrosal. The anterior petrosal is really through a middle fossa craniotomy where you come in subtemporally and you drill the petrous apex, and it creates a corridor that allows you to access the posterior fossa from a middle fossa approach. And why do we do that? Well, the main advantage is that you get really, really close to Meckel's cave, the petrous apex, and it brings you in front of the cranial nerves. So the cranial nerves are not in the surgeon's way, whereas opposed to the retrosigmoid approach, there are some lesions that are anterior to the cranial nerves, where the cranial nerves are in the way of the surgeon. Now, the posterior petrosal approach is what we commonly call the pre-sigmoid or retrolab approach, where you come in behind the ear and you come in through a mastoidectomy, a subtemporal craniotomy, and your access is pre-sigmoid, and you can cut the tentorium to access both supra and infratentorial. And you can also combine both of these approaches into the combined petrosal approach and do both anterior and posterior petrosectomy. So this is the view that you get from an anterior petrosectomy. You can access the brainstem nicely, the basilar artery, between the fifth and the seventh nerve. So this is a very useful approach for brainstem cavernomas. And of course, you can also treat petrous apex cholesterol granulomas, bony lesions like chondrosarcomas, and also vascular lesions of upper to mid-basilar aneurysms. You can combine the anterior petrosal approach with a posterior petrosal and sometimes combine it with an FTOZ approach as well. So the reason why I really like the anterior petrosectomy is this maneuver. If you open up the porus trigeminus and open up the fibrous ring, it opens up and decompresses the fifth nerve, and you have great access into Meckel's cave. And it brings you right on top of it. You have a very short distance to the target. You have a very short distance to the brainstem, and it lands you anterior to the seventh nerve and anterior to the fifth nerve as well. You can also access Dorello's canal. It really gives you this angle of attack. So you see how this tumor is situated right in front of the cerebellum, and look how medially it displaces the superior cerebellar peduncle and brainstem. if you did this through retrosigmoid approach, it may require, a significant degree of retraction. And by coming in middle fossa, Kawasi's approach, it gives you this type of angle of attack where you don't have to retract the cerebellum. And I'll show you the intraoperative view of that case a little bit later. We can combine this with an FTOZ as demonstrated here. And the key is when you're doing it frontotemporally, you do the standard incision, interfascial dissection. You can do an optional zygomatic osteotomy. It's not always necessary. I rarely do it, but sometimes if you're going infratemporal fossa, it's nice to make these cuts. And the key is to peel the dura off of the middle fossa floor. So we generally will ligate the ligate the middle meningeal artery at the foramen spinosum and start the peeling of the dura propria, which is the temporal lobe dura, and peel it off of the posterior cavernous sinus to expose V3 and V2. And the landmark that you must understand is the Fukushima middle fossa rhomboid. So if you understand this rhomboid, you can understand how to navigate yourself in the middle fossa. So you look for the back of V3, GSPN, the geniculate ganglion, which forms this corner, the arcuate eminence, and the medial petrous ridge. And it forms this rhomboid structure. And this structure is important because it helps you navigate where you are. So you know that the horizontal petrous ICA and eustachian tube are parallel roughly to GSPN, and the ICA is just inferior to this. And then the cochlea will be anteromedial to this corner. And if we bisect this corner at geniculate ganglion, we will find the IAC. So this is a cadaver dissection that I had done years ago. This is the back of V3, the GSPN, geniculate ganglion here, and the arcuate eminence and medial petrous ridge. So this makes the rhomboid structure. Now you see this ridge here that's more lateral. It's what we call the false ridge. It's not the true ridge that represents the arcuate eminence. So oftentimes when you see the first ridge as you're peeling, remember that this may not be the arcuate eminence. You must continue to peel until you see the second ridge. And this is the true ridge of the arcuate eminence that generally represents where the superior semicircular canal is. And then once you find this, then you know you're at the middle fossa rhomboid. So when you bisect this angle, this is the IAC, and anteromedial to this is the cochlear angle, where the cochlea is the basal turn, and you have to preserve roughly about 4 millimeters of bone there to avoid hearing loss. Now, when you're drilling the petrous apex, you should drill from a medial to lateral direction. I generally isolate the horizontal ICA early on so that you want to uncover the dangerous structures so that you avoid injury to them. So again, have that X-ray vision of where these critical structures are, avoid the cochlea, avoid the facial nerve, and avoid the horizontal ICA. So at the end, you get an exposure like this. Now understand that the IAC dura makes like a funnel. So the funnel, the porus acousticus medially is going to be wider. And as you go more distally, the canal is going to be more narrow. And as you go more distally, you'll come across the labyrinthine segment, which is going to be right at Bill's bar. And that segment is very vulnerable. So you have to be very careful, use a 1 diamond and shave the bone very carefully. Now this IAC will divide this rhomboid into a premeatal triangle and a postmeatal triangle. And in order to maximize the drilling of the postmeatal triangle, you really need to blue line and find the superior semicircular canal. And this postmeatal triangle is often underrepresented. It's actually a very useful triangle because when you open the dura here, it lands you right on top of the cerebellum, a little bit more posteriorly, and it can help you get better access below the 7th and 8th nerves. So remember to not compromise the post-meatal triangle. Most people focus on the pre-meatal triangle, and the limit is the inferior petrosal sinus, and then lateral to this will be the clivus. You can then mobilize V3 anteriorly and get more of the petrous apex hidden underneath V3 and drill off the rest of this until you get this exposure. And sometimes, if you need to, I try to preserve GSPN, but sometimes you can transect it and then you can mobilize the carotid out of the carotid canal. And then you have access to all of this infrapetrous bone, which oftentimes is useful to remove if you have a large chondrosarcoma in this area. By exposing the petrous ICA, this is a nice recipient or even a donor for a high flow bypass. And we studied this some years ago with Dr. Caldwell when I was a resident, and we collaborated with Professor Al-Mefti in Fukushima on this project. And this is really to we were trying to think about how can we do this Fukushima petrous to supraclinoid bypass in a better fashion. Unfortunately, this is a bypass that we rarely see these days, largely because of flow diverting technology for these giant cavernous aneurysms. But nevertheless, it's important to know the anatomy here and know that these are options in some rare instances that you may need. So when we open up the dura to access the Kawasi's approach, you have to open the dura along the temporal base. You open the dura over the posterior fossa dura, and then you have to cut the tentorium by ligating the superior petrosal sinus, and then you cut the tentorium to the free edge, making sure you stay behind the fourth nerve and the entrance of the fourth nerve. So you have to be careful not to injure the fourth nerve. It can be vulnerable. And then be careful with these stitches. I generally don't stitch this tentorium because you can avulse the fourth nerve, but just be gentle when handling that. And so here's the cadaver dissection showing the fifth nerve here, and then here's the seventh and eighth nerves. And then you can see the nice access to the brainstem and a ICA. If you angle the scope and you do more extensive cavernous sinus exposure, you can see the sixth nerve going into Dorello's canal. Remember that Dorello's canal is a venous confluence of a dural tube with the venous sinuses joined together from superior petrosal, inferior petrosal, and the posterior cavernous sinus. So let's take a look at some case examples. This is a 61-year-old female who had progressive headaches and ataxia. She has this upper petroclival meningioma, and it is a true petroclival because we define them as the meningiomas that arise medial to the fifth nerve. And you could see on this Fiesta scan that the tumor is medial to the fifth nerve with some brainstem compression. So we'll do it through this frontotemporal incision. And we'll go ahead and ligate the middle meningeal artery by polaring it at the foramen spinosum and then incising the artery. And then we'll start peeling. And I think you should peel from posterior to anterior. I know some people have advocated the other direction, but I truly believe posterior to anterior is the correct method because it's in the direction of the fibers and it peels much easier, keeping the GSPN down on the middle fossa floor. We're now dissecting the dura propria off of V3. Sometimes you have to use sharp dissection because it can be fibrous adhesions there and you have to use micro scissors or a 15 blade to gently release these fibers so you can get into that sweet spot. So you peel that dura propria off of V3. Here I'm decompressing the foramen ovale with a diamond drill so that I can release V3 in preparation to mobilize it anteriorly. So there's ovale, V3, and here is the middle fossa rhomboid. So now I have the rhomboid in my sight. I can visualize where IAC is going to be in the cochlea. So I'll begin my anterior petrosectomy from a medial to lateral fashion. I can mobilize V3 anteriorly, look for the trigeminal depression, And then I can eggshell this bone all the way down to the posterior fossa dura, skeletonize the horizontal petrous ICA. And now I've found the IAC dura. And we'll go ahead and open the temporal lobe dura inferiorly, go subtemporally and identify the supratentorial component of the tumor. We'll begin tumor debulking with an ultrasonic aspirator and carefully dissect the tumor away from the brainstem. And so here's the tumor being elevated. There's the superior petrosal vein. And we're being careful to look for the fourth nerve as we get to the tentorial edge. And then we'll go ahead and debulk more of this tumor up to the tentorial edge. And then once we get to the tentorial edge, we'll begin to incise it, staying behind the fourth nerve, and then we'll come in lateral to medial. This is this bleeding from the superior petrosal vein. You can put vascular clips, but I like to just bipolar it and seal down the opening if it's possible. And then open up the posterior fossa dura, and then finish the tentorial cut. So you really have to open up middle fossa, posterior fossa, and then straddle the superior petrosal sinus and then cut the tentorium to the free edge. And then we'll open up the arachnoid membranes over the posterior fossa. This is the superior petrosal vein going into the tentorium. We're just going to ligate that terminal branch. And then the key maneuver here is to incise the fibrous ring of the porous trigeminus. This allows you to follow the tumor into Meckel's cave. We're going to fully decompress the fifth nerve. And you see how after we've opened up the porous, all of that tumor in Meckel's cave is directly visualized. And you're working through a very wide
Niñas, ya. Les van a castigar la tele.
And now the tumor is carefully removed from Meckel's cave, and then we'll finish the dissection off of the brainstem. So you see how we're working in front of the fifth nerve? There's no manipulation of the fifth nerve. We're entirely in front of 5 and 7, and I don't have to worry about injuring 5 or 7 because we're working in front of the nerves. And really, this is one of the major advantages of the petrosal. There's the basal artery, there's the brainstem. And then after removal, reconstruction again is very important. So we like to do a multi-layered repair with a Duragen and then a little bit of fat to seal off the opening. And then I'll put another piece of Duragen there. And then I use a vascularized pedicled pericranial flap we harvest early on at the beginning. And then you can see it's pedicled posteriorly, and it's got a very nice coverage of the middle fossa. So here's the post-op scan, complete removal, and the patient was neurologically intact. Here's another example. This is a dumbbell trigeminal schwannoma, 38-year-old male with a little bit of facial numbness. Again, you can do this retrosigmoid and follow it into Meckel's cave, but these I like for Meckel's cave. I really like the anterior petrosal access. Here we'll come in again with a middle fossa craniotomy. Here's the middle fossa rhomboid, and then we'll drill the middle fossa rhomboid again from a medial to lateral direction. And there's the ICA, there's the posterior fossa dura being open, middle fossa dura being opened. We're now cutting the tentorium after ligating the superior petrosal sinus, and then this gives us access to the tumor. We're now going to open up the fibrous ring of the porous trigeminus, and then this releases the tumor. There's the fifth nerve right here into view. And then we'll start with dissecting the tumor. And when you're doing trigeminal schwannoma surgery, you have to preserve as many of these fascicles of the fifth nerve to avoid any worsening. So here's the main trunk of the root of the trigeminal nerve. And then we're going to peel the tumor away from the structures of the brainstem. And then here's the fifth nerve. The seventh nerve is behind here. And now we're working above the fifth nerve into Meckel's cave. and we'll debulk the tumor sharply. And it's important to piecemeal it because it makes it easier when you're rolling the tumor. You don't kink any important structures. So there's the final view. There's the brainstem. Here's the fifth nerve. You see how it's fully preserved, going right into Meckel's cave. So here's a complete removal. He's been recurrence-free now for roughly 8 years. So here's an example of a very large epidermoid tumor. You can see the bright signal and the DWI signaling. She had pretty bad gait ataxia and some hydrocephalus. So how would you approach a lesion like this? My initial thought was to come in retrosigmoid and debulk the tumor. And in retrospect, maybe I should have chosen another approach instead, but you'll see that I came in through a retrosigmoid, but I extended it to a far lateral because you can see that there was epidermoid extending below the foramen magnum, and coming in far lateral helped me get this component of the tumor. And then you can see there's 9 and 10, there's facial nerve, the fifth nerve. And then unfortunately, at the end of this surgery, I was irrigating and I saw this nerve structure floating in the cistern. And I knew that I had caused a transection of the sixth nerve, unfortunately. But if you see this, try to find the other end of the sixth nerve. The reason is because the sixth nerve can be repaired and you can restore the function if you are aggressive to find the two ends and re-anastomose it. Now, some people say just put the two ends together and put a little fibrin glue, but I really believe you should put a suture, because the waves of the CSF can wash your nerve away. And I'm afraid the two ends, if they're not sutured, they can float apart, and then you won't get recovery of the nerve. So here we're using a 10-0 suture, and we're tying a knot in a deep hole. So you just make the suture short so it's easier to tie the knot and thread the knot. And then you just need to put three knots to hold it in place. I then rest the anastomotic point on the petrous bone and then put a little Surgicel and fibrin glue. And then here's the final view. You could see sixth nerve, there's 7, and there's 9 and 10 below. And you could see I left residual tumor in this blind spot right here. And the reason why I couldn't see this is because the 7th nerve and 8th nerve was tethered so bad by the tumor that anytime I tried to mobilize the cerebellum medially, I would get activity on the facial nerve and get intermittent drops of the ABR. So I had to use an angled endoscope and some angled curettes to get it, but you can see this is a blind spot for the retrosigmoid approach. So at 4 months, you can see she's had some partial recovery. And surprisingly, at 7 months, she had full recovery of the 6th nerve, faster than I would expect. Usually the facial nerve takes about 1 to 2 years to recover, but look how fast the 6th nerve has recovered by 7 months. Unfortunately, at 9 months, this residual tumor began to grow. And now I had to make a decision of what approach I needed to take. And so in this case, I knew coming in retrosigmoid was going to be not successful because I had done it the first time already. I needed to come with an alternate approach, in this case, the Kawasi's approach. So you can see here's the middle fossa rhomboid. And I combined it with a mini combined petrosal. I went around the superior canal, did a little bit of posterior canal only because I wanted to maximize this post-meatal drilling. And so we open up the dura. Here's some veins. And we open up the tentorium, and you can see there's the 4th nerve. We're protecting the 4th nerve. And then we can open up and cut out all of that tentorium from above. And it gives you access to the top of the cerebellum. So now we're looking at that tumor from above. You can see it's right here where the instruments are. and it lands you right in front of the seventh and eighth nerves. So this is the seventh and eighth nerves. This is the tumor. Look how this approach landed me right in front of the tumor. Here's the seventh and eighth nerves. And I didn't have to retract the cerebellum to see it. And you can see after removal, 7 and 8 is nicely preserved. And then we can see the sixth nerve that was repaired previously. And then here is 4 and 5 completely intact. And then here's a gross total removal. And she had a very nice neurologically normal recovery. So let's talk a little bit about vascular lesions. This was a subarachnoid hemorrhage. The patient had a stroke already, and it turned out that she was an IV drug user. She had endocarditis, and she had this pseudoaneurysm here. You see the pseudoaneurysm here coming off of the SCA. And so this is the angiogram, the 3D reconstruction. You can see this looks very unusual. This does not look like a typical saccular aneurysm. It's off of the S2 or distal S3 SCA vessel. And it looks like this Hiroshima mushroom cloud. So when you see something like this, be very wary that this is a pseudoaneurysm, meaning there's no wall for this aneurysm. It's just going to be a huge hole in the artery. She has endocarditis, so these vessels are largely diseased. Fortunately, she already had a stroke, so that territory is not being supplied. So you'll see what we do here. So I decided to do this through Kawasi's approach and instead of retrosigmoid. And the reason being is because the Kawasi's approach allows me to see the SCA vessel in its horizontal length. So I have proximal and distal control. And I wanted to see if I could attempt to try to reanastomose it. And it would be easier to do it through this approach as opposed to a retrosigmoid approach. But you'll see what we do here. This is the petrosectomy, as you have seen demonstrated. And then we go ahead and open up the dura, cut the tentorium. And then there's the subarachnoid hemorrhage. I'm opening up the arachnoid over the posterior fossa. And then look what happens here. We're opening up, there's a lot of fibrinous exudate tissue, and there's a pulsation down there, and I'm not even touching it, and look what happens. Spontaneous bleeding. This is very typical of a pseudoaneurysm, so you always have to be ready for intraoperative rupture. This is very high flow. I tried to see if I could try to coagulate the bleeding point, but it was a lot of clot there and fibrinous tissue. So I just went ahead and put some clips just to get a little bit of control to stop the bleeding. And then now I have things under control. I can go ahead and dissect and expose the proximal artery. So I see the proximal artery now. So I'll now put a proximal clip, temporary clip on the proximal end. And we'll find the distal end here. See, now is the distal end of the SCA. And then now I can take off the initial 2 clips. And then what I found was, look at this. This is a diseased vessel. It's just a big smoking hole in the wall. It looks like someone put a shotgun into the wall of the vessel. So unfortunately, I was not able to repair this, but it wasn't really necessary because, you know, the patient already had a SCA distribution stroke. So just leaving the clips was adequate, and she was actually awake and following commands post-op without any residual pseudoaneurysm. So petrous apex cholesterol granulomas, I just want to touch base on a little bit of this. You know, traditionally, we were taught to plug this with vascularized flaps and so forth, and to resect every margin of the wall. And I think that's really not necessary for these types of lesions. You know, we've learned a lot from our ENT colleagues that all we need to do is to drain them and to leave the drainage passage patent, and these will drain and not recur. And we will typically do most of these endoscopic endonasal. However, in this case, I studied the film, and you can see here is the Petrous ICA, and then here's the prepontine cistern, CSF cistern. And so the window to get to this area endonasally was very narrow. So I didn't think this would be favorable for endoscopic endonasal. So we went ahead and used this middle fossa technique, which I published when I was a fellow with Dr. Delashaw. We opened up the Petrous apex cyst, and then you can thread a ventricular catheter in the proximal end. And then if you drill a hole between V1 and V2, you will enter the sphenoid sinus, and you can thread this catheter into the sphenoid sinus to allow the drainage passageway in this fashion. So we took this a step further. My otologist, Dr. Jiang, likes to open up the mastoid, and we can thread a second catheter from the cyst into the mastoid cavity, where it will drain into the middle ear and down the eustachian tube. So you have two drainage pathways. And we published this technique some years ago. And then you'll see this is the video showing the technique. We're going to elevate the temporal lobe dura, ligate the middle meningeal artery at the foramen spinosum. And then after transecting it, we can then elevate the dura propria off of the floor of the middle fossa. And in this case, we're going to elevate it off of the cyst wall of the cholesterol granuloma. You can start to see the greenish color of the cyst. Here's the GSPN, and we're dissecting posterior to anterior, leaving GSPN intact. And it's very important not to get a CSF leak, because you can't use this technique if you have a CSF leak, because you'll drain CSF into the nasal cavity. So here is we enter the cyst, and then you can see a lot of the typical cholesterol cyst contents, these crystals. And then this membrane here, this is the posterior fossa dura. The posterior fossa dura has now reinflated because it used to be compressed by the mass. And so that reinflation is a good sign that you've decompressed the brainstem. And what we're doing here is we're resecting the lateral wall of the cholesterol cyst. And you could see the medial wall of the cyst is stuck to the dura of the posterior fossa. So you can't really resect that wall. Otherwise, you risk getting a CSF leak. So what we're doing here now is we've drilled a hole between V1 and V2, and that's the sphenoid sinus. We're going to thread this catheter into the sphenoid sinus and then do the double exhaust ventricular catheter drainage. And so here is the post-op scan. This is at 3 months, and this patient has remained recurrence-free for 11 years now, and he regained his facial and hearing functions after that. And then again, here's the post-op scan. There's no recurrence. This has been 12 years, no recurrence. So let's change directions now and talk about the posterior petrosal approach. We said that this was a pre-sigmoid access. And then I often like to do a combined petrosal. I rarely do just a pure posterior petrosal. I always combine it with an anterior petrosectomy. And if the hearing is intact, I leave the semicircular canals intact and do retrolabyrinthine approach. Now see how in this approach, the superior canal and the posterior canal causes some obstruction. You can do a variation of this where you drill off the superior canal and the posterior canal, which is called the transcrucial approach, or what Dr. Shekhar calls the PLPA, partial labyrinthectomy, Petrous apicectomy. And this gives you extra access, unobstructed view to the petroclival region, and you can still potentially preserve hearing as long as you don't lose a lot of the endolymph while you're drilling these canals. So here's an example. This is a recurrent brainstem cavernoma. Interestingly, the patient was previously operated at another center. He had a previous retrosigmoid and then a previous EEA, endoscopic transclival approach. And despite this, the cavernoma still recurred. And you can see where it's recurring. It comes to the surface on the lateral, anterolateral brainstem. here is the fifth nerve, and then here is the seventh nerve. So I felt that a combined petrosal would be favorable. He has a lot of deficits already existed. He's got a left sixth nerve, seventh and eighth nerve palsies with right arm and leg weakness from multiple hemorrhages. And so my choice of approach here was, for this component, I can come in anterior petrosal, but since it extends a little bit lower into the medulla, I thought a combined petrosal would be an excellent option. It's important to look for the DVA, which is almost always there on a brainstem cavernoma. You must preserve the DVA so you don't get a venous infarct. And so what I did was, this was his previous retrosigmoid incision in the shape of an S, and then I naturally extended it behind the hairline to do my combined petrosal approach. I do a temporal craniotomy, and then I do an extended mastoidectomy, and then we harvest this big vascularized pericranial flap. And we published this video not too long ago. So we'll go ahead and elevate the temporal lobe dura and find GSPN, and again, dissect it from posterior to anterior. There's always sharp adhesions of periosteum overlying the nerve, so you have to use sharp dissection and then coagulate the middle meningeal at the foramen spinosum. You can use a little bit of Surgiflow for venous bleeding, and then we'll drill the petrous apex in the fashion that we had described, finding the horizontal petrous ICA, and then eggshelling it down to the posterior fossa dura. We'll then go ahead and do a retrolabyrinthine mastoidectomy. You open up the mastoid antrum, and you can find the incus and the lateral canal. Once you find the lateral canal, you can just skeletonize and find the other canals, which are relatively 90 degrees to each other. So there's the superior and posterior canal. And then we'll finish off the petrous apex resection doing this combined petrosal approach. And then we'll go ahead and be prepared to open the dura. We'll open the dura along the temporal base, leaving the temporal lobe covered with dura. And then there's the tentorial edge. We're going to lift up the tentorium and cut the middle fossa dura, so we're right on the tentorium. We're going to open up the middle fossa dura here. I'm sorry, this is the posterior fossa dura. And then we'll cut the superior petrosal sinus. I like to just ligate it with a bipolar and then finish the tentorium cut. You always have to look for the fourth nerve. And there's the fourth nerve, so you want to make the cut posterior to the insertion of the fourth nerve. There's the fifth nerve. And then we'll open up the arachnoid around the fifth nerve. So we have a lot of working corridors. We can work between 4 and 5, below 5, or above 4. Now I'm opening the pre-sigmoid dura. Unfortunately, there was a lot of scar tissue there from the previous retrosigmoid, so I decided to work only from the Kawase anterior petrosal corridor. So there's the cavernoma. We're just carefully dissecting it from the brainstem, and it's coming out in a piecemeal fashion. Now you have to remember that if a patient had previous surgery for brainstem cavernoma, there can be a lot of fibrous tissue, which we saw here, and there can also be seeding, meaning that previous removal may have left not just one residual, but more than one seeds of residual, so they may not always be together, which is what we saw in this case. So this is the exophytic component. And then based on image guidance, there was more cavernoma in the brainstem higher up. So you can see how the hemosiderin stained brain is visualized. And using image guidance, I make a small corticectomy above and below the fifth nerve, and I can find more cavernoma here. And then we'll carefully dissect around the cavernoma, looking for this nice gliotic plane. And then this little area of tissue is really not functional, so I'm going to go ahead and just communicate the two corridors. And then this allows me more room and access to the remainder of this cavernoma. I like to use a gentle, a fine bayoneted forceps. I use this to dissect and to peel the cavernoma from the brainstem to separate it. There was a lot of fibrous scar tissue here, so I had to use a lot of sharp scissor dissection. And then you can see this is a very, very fibrous. So here is an example where it's very fibrous, and I have to use a heavier blade scissors here to cut these fibrous bands and then remove these areas of excess. Now, there's the DVA, and you have to recognize that that's a DVA and not a cavernoma, so you don't accidentally grab it and then cause venous bleeding. I always like to use an endoscope at the end of the surgery so I can look around the corners, look in between the cranial nerves to inspect. And then there's the DVA, nicely preserved. And then here's a gross total removal, multi-layered repair with a Duragen. And you have to seal off the middle ear, the antrum. And I'll often use a little wax plug followed by a little bone cement for a little bit more sturdiness. And then here's a fascia lata graft reconstructed. And then the pericranial flap rotated from posterior. Here's the CT scan showing the double petrosectomy. You can see anterior and posterior petrosectomy, getting you that access. And then here's the post-op scan. You can see the cavernoma is completely removed. And then he had an excellent outcome. He was able to regain all of his function. He only had a little bit of trace weakness on that left side. And so here's the DVA nicely preserved. So the combined petrosal approach, I largely use for these types of petroclival meningiomas. I find it very useful. Again, it really lands you right in front of the cranial nerves. And so we'll do this through a large C-shaped incision, patient here in the lateral position. And then we'll harvest the extended pericranial flap. And then we'll do the temporal craniotomy with an extended mastoidectomy. What I mean by that is I drill and skeletonize the sigmoid sinus. I don't like to turn a bone flap across a big venous sinus because the foot plate can potentially tear the sigmoid sinus. And if you tear the sigmoid sinus, your surgery is pretty much aborted and it doesn't do you any good. So I just do a big temporal craniotomy and then an extended mastoidectomy, and I skeletonize and I craniectomize the retrosigmoid area. Now, this is important to do because you need to expose the retrosigmoid dura so that you can mobilize the sigmoid sinus posteriorly. And that's how you widen this surgical corridor of this Troutman's triangle. So here's the video demonstrating the retrolabyrinthine petrosectomy. I've blue lined the canals so I can get as close to the posterior canal as possible to widen my pre-sigmoid corridor. I'm opening up the middle fossa dura and then ligating the superior petrosal sinus, cutting the tentorium. And then here is the superior petrosal sinus here. Here we're using the suture ligature. We're going to tie that off and then cut the tentorium towards the free margin. And then you can see there's the tumor already. Here is the 7th and 8th nerves. And then fortunately here, the tumor was soft and suckable. And then we're using this fine microbayoneted forceps to peel the tumor from the brainstem surface. And then as I debulk the tumor, I have more working space and I can cut more of the tentorium now. And I cut it all the way to the porous trigeminus. So here is the 5th nerve. We're working above the 5th nerve, debulking the tumor. And then we can work underneath the 5th nerve. And then here's the last component of the tumor being devascularized. So the advantage of cutting this tentorium is that you're actually devascularizing the tumor as you're cutting the tentorium. It's largely supplied here. And so once the tumor is more devascularized, it becomes softer by the end of the surgery. So as the surgery progresses, the tumor removal tends to become a little bit more easier because the tumor is softer. So here's the last arachnoid bands that are being dissected. And then after removal of the tumor, again, we use the endoscope to look around corners, to look at the resection cavity, and we'll do a repair here. I like to use autologous fascia lata. It's a great material, heals very nicely. And then we create a fascial sling to hold the fat graft. And we publish this when we do translab for acoustic. So instead of putting the fat through the defect where it touches the brainstem, I like to suture in this fascia lata sling with interrupts sutures, and it creates like a hammock, you know, a little sleeping hammock on the beach, where the fat graft will rest on there, and it prevents the fat graft from herniating into the defect to compress the facial nerve or the brainstem. So here you can see, here's the fascial sling, here's the fat graft, and then I like to put the MedPore plate on top to push the fat graft, to put a little bit of pressure to prevent pseudomeningocele. Again, here's the double petrosectomy, post-op CT scan, and then here's the post-op MRI showing complete removal. This is post-op day 1, and then this is at several years post-op, and you can see she's had a very nice neurological result. So this is another deep petroclival lesion. You can see it's multicystic. It's got variable enhancement. It goes into Meckel's cave. The presentation is left facial numbness. So what is this diagnosis? This is a cystic trigeminal schwannoma. And here we'll go ahead and do our petrosectomy. We'll go ahead and open up the presigmoid and temporal lobe dura, and then cut the tentorium into the free edge. And then the arachnoid dissection will open up the cistern in the posterior fossa. There's the tumor in the presigmoid window. We'll open up the arachnoid membrane. There is the trigeminal nerve. There's the trigeminal nerve again. We'll stimulate it to make sure it's not the 7th nerve. Sometimes the masseter muscle will trigger, so you have to make sure you distinguish masseter muscle from facial nerve muscles. And so there's the brainstem. So we can now start to carefully dissect the tumor from the 7th and 8th nerves that you see here. So I'll use a combination of a disc dissector with fine microbayoneted forceps. But look how I'm working in front of the 7th nerve. The 7th nerve is not in my way. I can work right in front of it. There's the 5th nerve. I can work around it. And then this is the tumor anteriorly. I'll finish the cutting of the tentorium to create more working space. And so we'll reset the retractor so we can look for the 4th nerve. There's the distal SCA. There's the 4th nerve. And then this allows me to remove that last part of the tumor. We'll go ahead and open up the porous trigeminus. There is the tumor in the Meckel's cave. And then I'm preserving all the fascicles of the trigeminal nerve. There's the tumor that's going into Meckel's cave. And then we'll go ahead and debulk more of this using the ultrasonic aspirator. And the difficulty here, the challenge is always finding the 6th nerve. The 6th nerve is always the last one, and it's the most medial one, and it's easy to injure if you're not careful. So there's the last remaining portion of the tumor. And there's the 6th nerve. I left a little microscopic adhesion to the 6th nerve, so I wouldn't injure it. But you will see it's radiographically not visible on the post-op MRI. There's the basilar artery, and there's the 7th and 8th nerves. Little small tumor adhesion I left. I didn't want to be aggressive and injure the nerves. Here's the fascial lata sling and a hydroset cement with fat graft and a little bit of dural repair and a pericranial flap reconstruction. Here's the post-op scan. You can see radiographically complete removal. You don't see those areas of microscopic adhesions. Nice decompression of the brainstem, and the patient was neurologically intact. So can you use petrozole for vascular lesions? I have used them for several. One classic example for me is this deep petrozole cerebellar AVM. It's in the quadrangular lobule juxtaposed to the brainstem. This is a subarachnoid hemorrhage. You can see the pattern of the hemorrhage is very unusual. It's following the tiger stripes of the fovea of the cerebellum. And then the angiogram shows that it's a very small micro AVM coming off of the distal SCA. And so I decided to do this combined petrozole instead of retrosigmoid because I didn't want to work in a deep hole and not have control of the SCA vessel. Whereas in a petrozole approach, I get this type of exposure of the SCA and I have wide control of the SCA vessel. So here's the craniotomy. This is the vascularized pericranial flap. We'll do the combined petrosectomy with anterior petrosectomy, combined approach, and then we'll go ahead and elevate the temporal lobe dura and then open up the arachnoid here. And then you can see the cerebellum here has a hemosiderin stain right here. This is the 5th nerve. This is the SCA. And then here's the SCA. And you'll see as we're devascularizing the AVM, notice this vein here, it's arterialized, but watch how it turns blue as I'm taking away some of these fistulous connections. So you see how the vein is turned blue, and then I've made a corticectomy. I'm looking for the AVM, and you can see here's the surface of the AVM. It's got a little bit of char on there, and we can work in that white matter plane and then carefully dissect the AVM from the white matter. And the beauty of this approach is that I'm not working in a deep hole. I'm actually working in a very wide corridor. I have good control of the vascular feeders. And here's the last component. You can see there's the AVM. It's a small micro AVM. And then there's the resection bed. You could see the nice white matter in the resection bed. Here's the post-op angiogram, no residual AVM, a nice removal. And I think this is a very nice approach for these deep cerebellar AVMs. Now, the posterior petrosectomy can have a variety of variations. So this is the retro lab where we preserve all of the otic capsule, but you can do the transcrucial variant and take away the posterior and superior canals, and you have more access to the petroclival region. And if you take away all of the canals, this is the trans lab. And the most extensive one is to do a transcochlear where you mobilize the facial nerve posteriorly. You have to transect GSPN, and you get this huge access to the petrous apex. However, you do have a facial nerve palsy post-op that recovers to as good as a Brackman grade 3. So this is met with some morbidity. So we rarely do this approach, only in select cases. But this is the illustration demonstrating the transcrucial approach. When you drill this and enter the semicircular canals, you have to pack this off with wax so you don't lose the endolymph and get hearing loss. But this is the exposure you get a better access. And I use this approach in this large tumor. This is a petroclival meningioma. You can see it extends into Meckel's cave, superior and infratentorial components. And again, the reason why I chose petrozole is look at this angle of the tumor, and look how the brainstem is wrapped around the back of the tumor. So if you did this retrosigmoid, you'd have to retract all the cerebellum, and there'd be excessive retraction on the brainstem, and you can harm the patient that way. So a combined petrosal, no cerebellar retraction, and you can get this type of result and preserve all of this area with no retraction injuries. I'm going to change directions to jugular foramen and show you how mastoid Transpetrous approaches can help you with jugular foramen approaches. This is a temporal meningioma that grew into the infratemporal fossa. It was treated by another surgeon many years ago and had a residual that was stuck onto the petrous ICA. You can see the tumor residual here. It was treated with radiosurgery. However, the tumor grew back and was now invading into the petrous ICA, but also now into the jugular bulb. And the patient had developed a complete facial palsy because the tumor had invaded the facial nerve. So she has a complete facial weakness. And so we did this total petrosectomy transjugular approach with facial nerve grafting. I did a balloon test occlusion on the patient and she passed. So our plan was to go ahead and resect the tumor infiltrated ICA that you see here. And we also opened up the jugular bulb. So we go ahead and tie off the internal jugular vein. We occlude the proximal sigmoid sinus, and then we open up the lumen of the jugular vein, and then we can remove the tumor that's in the jugular wall. So this is the post-op resection bed. Here's the infratemporal fossa, and then here's the sixth nerve here in the CP angle. So we found the two ends of the facial nerve. This is the mastoid segment, and this is the cisternal segment coming off the brainstem. You can see the nerve fascicles. You can harvest a sural nerve graft and do end-to-end anastomosis, and we'll reconstruct the middle fossa floor using this MedPore Titan implant. And then you can see this is the total petrosectomy. The whole petrous bone has been removed, and then complete removal. And this is her facial nerve. She started off as a Brackman 6, and she recovered to, I think this is a little bit better than a grade 3, maybe a 2.5, but you can see a pretty good facial nerve result with restoration of her mid-face, and her smile is actually pretty good here. So this is the article I was fortunate to write when I was a resident with Dr. Caldwell and studied with Dr. Fukushima on this jugular foramen approach of his. So you expose the mastoid and the internal jugular vein in the neck, and you take off the mastoid tip. So you have complete exposure of the jugular bulb. And this is great for glomus jugulare tumors. And so the jugulare tumors are in the lumen of the bulb. So you tie off the internal jugular vein, and you occlude the sigmoid sinus proximally, and then you can open up the jugular bulb and take out the tumor. The key here is to preserve the medial wall of the jugular bulb. And then this allows you better chance at preserving these lower cranial nerves. And then if the tumor extends intradurally, then you have the option of going intradural as well as extradural. And then this is the illustration from Alv Mefti's text showing the isolation of the sigmoid system, and then preserving that medial wall of the jugular bulb to preserve these lower cranial nerves. So here's an example of a patient with a winged scapula. Winged scapula is not only the long thoracic nerve, but it can be from the spinal accessory nerve as well, and as well as the dorsal scapular nerve. He has tongue atrophy, 11th nerve palsy, and swallowing difficulty. So he has cranial nerves 9 through 10 palsies. You could see on the MRI, he's got this bright T2 lesion. It looks like a chordoma, but don't be fooled. It's not midline. It's actually parapharyngeal. It's very extensive, going into the parapharyngeal space and invading the jugular bulb and going into the CP angle, compressing the brainstem. So how do you approach a tumor like this? You could see the tumor has eroded the lower clivus and the entire occipital condyle. So the patient has craniocervical instability as well. So we go ahead and we did a tracheostomy and feeding tube several weeks prior to optimize his nutrition because he couldn't swallow. You need to optimize nutrition so they can heal post-surgically. And so we'll do this lateral transjugular skull base approach where we skeletonize the fallopian canal and we do a fallopian bridge technique. This is the tumor that's eroded the occipital condyle. There's no occipital condyle, just soft tumor. This is the V3 segment of the vertebral artery. We've opened it from the vertebral transversarium. This is the fallopian bridge technique where we'll leave the facial nerve intact and work in front and behind it. And so we'll go ahead and tie off the internal jugular vein, open up the sigmoid sinus, and occlude the sigmoid intraluminally. So now we can inject Surgiflow that's going to go towards the back bleeding from the inferior petrosal sinus. We can then start to resect the lateral wall of the jugular bulb to access this soft tumor that's in the jugular bulb, and then remove it, preserving the medial wall. Now here's the rest of the tumor that's in the parapharyngeal space. We're going to retract the carotid arteries laterally, and then gives us great access to debulk the rest of that tumor. And then we'll cut out the internal jugular vein, follow it up to the jugular foramen. And then this is the remainder of that occipital condyle. It's like a loose tooth. And by drilling it gives me access to the rest of the soft tumor that's at C1-2 junction. We can then drill off the lower clivus. This is the lower clivus that's being drilled. And this is the tip of the odontoid. So you do not have to transpose the vertebral artery in this case. You can get right to the odontoid process and then remove all of that soft tumor. We'll go intradurally and find the tumor that's compressing the brainstem. Here's the vertebral artery. And the patient has no function of the lower cranial nerves. So you can transect these lower cranial nerves. They're adherent to the tumor. And in this case, you want to resect all of that, the dura. And so there's the clival dura that's invaded, and there's the vertebral basilar junction. Brainstem's nicely decompressed. To avoid CSF leak, you have to do a multi-layered repair. We're using alloderm, and then you have to close off the middle ear with some bone wax. And then we'll use a fat graft and then put pressure on it with a MedPore Titan plate. So here's the pre-op scan. Here's the post-op scan. This was a total, radical near total removal. I think I might have left a small piece of adherence to the vertebral artery, but overall a very good removal. We did a second stage occipital cervical fusion, and he did wonderful and went to radiation therapy afterwards. So the last case I'll show you here, this is a glomus jugulare tumor. You can see it's got the salt and pepper signal. You can see it's invading the entire jugular vein. Almost looks like a glomus vagale tumor. And then embolization is very important in these tumors. So we get a good embolization pre-op. And then we'll do the infralab mastoidectomy transjugular approach. There's the middle ear being waxed off. And then there's the neck exposure. And we'll go ahead and tie off the internal jugular vein. And then we'll occlude the sigmoid sinus proximally, intraluminally. And then we can inject the Surgiflow distally towards the inferior petrosal sinus. We'll open up the lumen of the jugular bulb. Here you can see there's the tumor being exposed, more bleeding from the inferior petrosal sinus. We'll pack that off, and then here's the bleeding from the middle ear. This is tumor in the middle ear. This is a glomus jugulotympanicum. And then here's some coil mass from the endovascular embolization. You can see the coil mass. And then we'll finish removing the upper portion of the tumor towards the jugular bulb. And then a little bit of Surgicel is also good and useful to stop bleeding. So we're going to open up the soft tissue between the mastoid tip that's been removed and the upper cervical region. It's important to find the rectus capitis lateralis. If you divide this really exposes the jugular vein. There's the top of the internal jugular vein here. That's tumor intraluminally. We're just using sharp dissection to get this exposure. And then there's the nice wall of the lumen of the jugular vein. So now we'll go ahead and open up the lower part of this tumor. This is opening up the internal jugular vein. And as we open this, you can see there's the tumor that's intraluminally. And then we'll finish this opening to communicate it together. And then there's the jugulare tumor inside the jugular vein. It's got a nice, smooth, encapsulated surface. And there's the tumor being removed. And here's the final removal. So this is all extradural removal, lower cranial nerves intact, even though they were already impaired pre-op. And there's the final view, no CSF leak. We'll just put a little fat graft and a MedPore Titan plate. So here's the reconstruction with the MedPore. And then here's the post-op scan. She was Brackman grade 1. She had a temporary feeding tube since she had pre-existing dysphagia. And otherwise she did very well. So I'll conclude here. I think the Transpetrous approaches are still very important strategies in our armamentarium. And sometimes they can be more advantageous than the retrosigmoid approach because it gives you different angles of attack to the brainstem and the desired target. And I think as a skull-based surgeon, you really need to master the temporal bone and really be like Michelangelo or be like an archaeologist and really uncover those hidden structures within the bone. And again, thank you again for this opportunity. I appreciate your attention.
Thank you. Thank you very much, Dr. Leo. It was amazing. You know, I invited you because I know you're a master in lateral skull-based approaches, and I really appreciate your time. You know, I know you're very tired right now. I just got a few questions for you. Everybody is encouraged to ask you any questions they have. So I would like to know if you have any considerations for, especially for us that are, you know, junior neurosurgeons, for drilling the ICA, you know, around the ICA to make it very, very exposed. I feel, you know, it's kind of scary for me to drill all over the, you know, all the Petrous ICA. What recommendations do you have for us?
I think the initial level of experience, I think, is you start in the lab, right? You start in the lab, you understand the anatomy, but not only understanding the anatomy, you use the laboratory as a simulation for how you will drill in a live patient. And so when you're drilling temporal bone, you have to think about, you know, the different drill bits that you have. And this is just practical stuff, right? So, you know, the cutting burrs are more aggressive. The matchstick is more aggressive. So when you're drilling through things that you can go through quickly, like the outer mastoid shell, air cells, you can use a more aggressive cutting burr. But once you get to more critical structures, you're using diamond burrs, coarse diamond, and they come in different sizes and different lengths. So you have to pick the right length so that you're resting your hands in a comfortable place, and the instrument is just the right depth. It's not too long, it's not too short. And then you have to understand when you're drilling with a diamond, how do you drill on critical structures without injuring it? and it's a very delicate touch, and it's a side-to-side motion. It's a lot of constant irrigation. Having a good assistant irrigating is good, or if you're working by yourself, a double barrel suction irrigator that the neurotologist uses is very good. But I find those double barrel ones a little bit bulky because it takes up room in a deep hole. So generally, I like to use a smaller sucker and have a good assistant giving me constant irrigation. But it's being able to see the soft tissue, and then you can use a gentle touch when you're drilling right on the sigmoid sinus or right on the facial nerve. I usually like to leave bone on the fallopian canal. I don't like to uncover that because unless, in most cases, you don't have to. You can work around it and leave it protected. But when you're drilling the IAC from a Kawasi, you have the dura to protect you, because the dura, the nerve is not in that dural fold. It's actually farther away. But as you go from lateral to medial, as you get closer to the fundus, the nerve, it gets closer. And so that you have to be more careful. And as long as you keep the dura intact, you can gently skeletonize it. And certainly, I think working with our otologists, I've learned a lot from them, and I watch how they drill, and I try to mimic, what they do, and I find that to be helpful.
Thank you very much. Sorry, the second question I have is, do you have had any complications for air embolization and infections when you go also through the mastoid cells, or how you deal with that, especially for air embolization?
Yeah, I haven't had air embolization. Are you talking about like venous air embolization, like sitting position type venous air embolization?
Yeah, right, for those combined approaches.
Yeah, I haven't had venous air embolus, but you do have to be careful. You can have venous sinus injury because the sigmoid sinus is exposed. So you always have to keep that moist. So I always put, there's this type of collagen sponge called Bicol. It's not gel foam, but it looks like gel foam, but it's better than gel foam because at the end of a long surgery, when you peel it off, it's not sticky. It actually comes off easily. But gel foam, as you may know, after a long surgery, if you try to take it off, it's very stuck to the brain or to soft tissues. And, it can cause bleeding because it's stuck to everything. So I like to use Bicol. And, sometimes you can have a little puncture hole when you're doing the mastoid drilling. So you just have to put a little gel foam and some pressure on it. And then at the end of the surgery, I always use a micro Doppler to assess the patency of it. But occasionally you can have sigmoid sinus thrombosis. I've had, one or two of them, but luckily they were not symptomatic. So I didn't anticoagulate. I just left it alone. But in terms of CSF leak, you have to make sure you have to close off the middle ear, the mastoid antrum. And I like to use a wax plate followed by some cement and fat graft. And so you have to make sure you don't have opening. I did have pneumocephalus though. There was an opening somewhere, and air from the nasal cavity can go into the posterior fossa. And so in those cases, either you have to go back and find the opening, or sometimes I'll come in endoscopically and I'll plug the eustachian tube with my ENT colleague, do endoscopic eustachian tube obliteration. And that saves them a bigger surgery.
Right. Thank you very much. Yeah, it's complex, As I asked you for the patient, I showed to you the meningioma, the middle fossa meningioma. I had never used this S-shaped incision, and I really appreciate that. But I have seen that you use a pretty straightforward combined approaches in the same time. Is there any contraindications for doing this both combined approaches in the same procedure, like not going in two stages?
That's a good question. You know, when I first started, I tried to do it in a single stage, and I realized it was a very, very long surgery. And, you know, then I started to stage them. So I would do the approach first, all the bone work, but not open the dura, close the wound, leave the patient intubated overnight, and then do the tumor resection the next day. So I think that is a good approach. But as I developed more years of experience, I became very fast with the approach. So now I just do it in a single day now, because I can finish all the bone work by 1:30 p.m. and then I have more time for the tumor removal. But when I first started doing this, and I was working with one of my ENT colleagues, you know, he's very meticulous and he takes more time, and it would be, you know, 3:30, 4 in the afternoon. And I just thought, if it's a big tumor, a difficult tumor like petroclival, you want to save your energy and, you know, first thing in the morning. So staging is actually a very good idea.
It's pretty challenging. It looks very, very, very difficult technically talking. So thank you very much, and congratulations on those, because I really appreciate your time for that. I don't know if anyone would like to talk or make any question to Dr. Liu. Otherwise,
Yeah.
there you go, Joel.
Hello. Hi. Good to see you, Edgar. Hello, Jim. So I do have a question. It's actually related with your experience as well. If you were to look back at, when you're, had started on this and now, what do you think were your initial, maybe limitations on the approach that now you can get like a better approach, or also in terms of reconstruction or even tumor resection? What do you think it changed over the years with the experience in order to, to maximize your experience and improve the results?
I think doing the combined petrosectomy gives you more options. So if you try to do everything pre-sigmoid, sometimes you get in there and you realize, man, my pre-sigmoid window is so narrow. But having that middle fossa option is great, because sometimes you have to come middle fossa, sometimes you have to come pre-sigmoid, sometimes you go right in between on that ridge, that petrous ridge that you call peripetrosal. I think opening the bone behind the sigmoid is very important. I always use lumbar drain on these combined petrosals, because sometimes you don't drain enough CSF, and it's nice to have that lumbar drain. And it's also good to have the lumbar drain post-op to help you with CSF leak repair. And I think the other thing too is when you're drilling that, the pre-sigmoid, if you're doing retrolab, you really have to hug the posterior canal and to get behind it, because there's often like a lot of bone that you don't remove, and it's actually obstructing your view. So you really have to hug it. And then in select cases, you can do the partial labyrinthectomy, take away the posterior canal if needed, take away the superior canal if needed, and it really buys you a lot of room. And then just remember to, wax the ampulated ends. Usually I'll actually drill the ampulated ends, which are the, I think of it like the arms, so this is the superior canal, this is the posterior canal, and the ampulated ends are the distal ends. So if you drill those first and you wax them off, then you can drill the rest of the non-ampulated ends towards the crus, and then it makes it easier. But I've found that maneuver gives you those few millimeters gives you a lot of space. Always be mindful of the veins of Lebet. That's a source of potential injury. So there can be more than one vein, and I usually cover them with the Bicol, keep that area moist, and just be mindful of your temporal lobe, so you're not retracting it. I try to not retract it as much as possible, but sometimes you have to use little intermittent, retractor where you lift up just enough to see the top of the tumor, and once you get control of it, you can ease up on the retractor or maybe even remove it. So, but just be mindful of those technical points.
Thank you.
Thank you, Joao. Thank you, Dr. Liu. So I don't know if anybody else would like to ask anything else. Dr. Gomez Salvador, maybe, that is also here. Bienvenido, Dr. Gomez.
Hola, hola. Hello to everyone. I just want to thank Professor James Liu. This has been a very good evening with him. I saw him just a few hours ago. I think one of the most important things that Dr. Liu is teaching us today is that the laboratory training is mandatory to perform all these kind of surgeries. And another important thing that I learned, that I have learned today, is that there is the common sense surgery. So there are different steps of the surgery that if you think very well in the preparative stage, it comes a very natural way to perform the surgeries. So I really want to thank the Professor James Liu for these excellent lectures of this evening. And I congratulate you, Edgar Ordóñez, for the organization of this magnificent event. Thank you.
Dr. Gomez. I'm pretty sure that you're very you're very tired, Dr. Liu. I'm so sorry to have you here.
No, not at all. I'm fine. I'm happy to entertain any questions. No, don't hesitate, please. This time is yours. So
I really enjoyed, as they say in the chat, every second of this lecture. I know that it's very motivating for us to keep on doing laboratory training. I have spent some time in the lab, but I haven't had time because it's time taking for improving those skills at any place in the skull base. Even if you are going endoscopically endonasal or going laterally, I find it very difficult to drill special spaces, or when you're going endonasally, cutting the medial aspect of the optic canal, and all those skills that you need for each procedure are very challenging. So I will need more time for doing lateral approaches. I don't feel comfortable yet to do those anterior petrosal approaches, especially. Maybe going and peeling the posterior aspect of the middle fossa is not that challenging in the technical point of view, but I feel that after drilling the apex and going ahead of that, I don't like to feel that small surgical view and dealing with all the cranial nerves in that deep space. I don't know. But do you recommend us to go in that kind of corner, because it's like a corner in all your field of view? What do you suggest to train that, like going in this direction?
yeah, I think what's helpful is if you're doing a Kawasi's approach, try to do it through a wider middle fossa craniotomy. So you're not working, you want to convert a narrow cone into if your bony opening is wider on the surface, you have a wider cone. And then the idea is when you drill the petrous apex, you're opening up the inner cone. So instead of a narrow triangle, you're trying to make it more like a cylinder, if that makes any sense.
Yeah, right.
So
Yeah,
you want to
because-
open the outer cone and the inner cone as well, so you maximize all that room.
Yeah, right. Because I don't know if you have felt that when you go inside that there's a triangle, right, just in the corner of the Petrus apex, and there's like where I find it very difficult to go through because it's very small, that space, and probably when you drill out all the bone around the ICA, probably that's the space that is that you gain through the surgery. I guess so. I haven't had the chance to take a look in a procedure. I would like to go and see your procedures one day. Those are impressive. Thank you. All right. So, well, Dr. Liu, again, thank you very much. And I hope to have you a different day, different topic again. So have a good night. Thank you very much.
Okay, thank you, Edgar, and great to see everybody. Juan Luis and JP, great to see everybody. Thank you again for this kind invitation.
Thank you. Bye. Have a good night.
Okay, good night.
Good night, everyone. Buenas noches, Edgar.
Buenas noches, doctor Amador. Muchas gracias por su presencia. Gracias a todos por asistir. Thank you very much to everyone for your assistance in this lecture. Good night.
Good night.